Hello, boot campers, and welcome to the boot camp entitled Healthcare Provider Professional Reimbursement. We're glad you joined us today as we traverse the workers' comp landscape and gain strength in all workers' comp administrative and billing and reimbursement exercises. This presentation is geared towards healthcare providers who are billing professional charges or medical items on a CMS 1500. Facility reimbursement, ASC reimbursement will not be covered in this presentation. So it's all professional fees on a CMS 1500 less ASC. We will not be covering hospital or specialty hospital reimbursement today. However, we welcome all system participants, whether you are an individual practitioner, a facility, or an insurance carrier, or even an employer. Welcome. So we're moving through the obstacle course from the log run last time to the ring swing today. And we're going to show off your upper body, chops. So this is going to require some upper body strength. So today we would like you to learn how to calculate professional reimbursement. Our professional reimbursement is generally based on Medicare policies, but there are always exceptions. We'll go over that today. Our team, or I like to use the term AMAT, A-M-A-T-T. It's all Medicare all the time, unless our rules or laws say otherwise. Today, you're going to learn some of those exceptions where our rules supersede or prevail over Medicare payment policies. We also hope to strengthen and stretch your workers' compensation chops and teach you how to bill workers' comp specific services like case management or functional capacity evaluations or other services that we call workers' comp specific services. So this webinar is based on 2026 professional reimbursement rates and rules. And as you're warming up, know that there are some responsibilities that fall on you, the system participant. Maybe you're an insurance carrier, healthcare provider, or even an employer. We at the DWC, and especially this team, always do our best to educate you on navigating the obstacle course of workers' comp in Texas. Our information presented today is good as of June 16th, today. However, you are ultimately responsible for knowing the laws and the rules of our system. You will find helpful links on that second handout to the laws and rules and the healthcare provider relevant locations on our website. However, just using the workers' comp topics A through Z on our homepage will get you to A for ACT, which is also the law, and R for rules, which is also known as a Texas Administrative Code. The best system participant is one that knows the relevant rules and laws inside and out. Let's go over what we're going to cover today. The first item is Chapter 134. If you want to know anything about reimbursement, most of it lies in the Texas Administrative Code, Chapter 134. This is where the money is. This is where the reimbursement is, and some of the billing CPT codes. We'll go over all of that in Chapter 134. In 134 is the medical fee guideline for professional services. Primarily, that's what this presentation covers. We'll go through some reimbursement calculation examples. Fair and reasonable reimbursement, which is really important to understand that concept in our system. The workers' comp specific services that I talked about. And some miscellaneous reimbursement. Now let's start reviewing our playbook for reimbursement, and that is Texas Administrative Code, Chapter 134. This chapter includes most of the rules regarding how much you're going to be reimbursed for non-network medical care in the Texas workers' compensation system. If you're training your staff, you would have them read Chapter 133 for the billing rules, which we covered in the previous webinar, and the timeframes. That's all in Chapter 133. And then Chapter 134 is reimbursement. So I would have staff read 133 and 134. So let's go through 134. This is how 134 is broken down into subchapters. Subchapter A is for reimbursement policies. Subchapter B, miscellaneous reimbursement. C, the medical fee guidelines. E is where the hospital fee guidelines and the ASC fee guidelines live in subchapter E of chapter 134, which we are not covering today, and pharmaceutical benefits in F. So if you want to know the pharmacy fee guideline, that's in subchapter F. Our fee guidelines apply to non-network medical services. And to be sure you understand the applicability of these fee guidelines, they do not apply to workers' compensation network claims. That reimbursement is negotiated between you, the healthcare provider, and the network, with some exceptions. And those exceptions are listed here. The first one is for designated doctor, required medical exam, and the treating doctor impairment rating exams. Those fees are set every year since 2024. They change every year, but they are set, and no discounts should be applied to any one of those services. Our fee guidelines apply there. Medical examinations for supplemental income benefits, treating doctor for compensable injury. Also, out-of-network healthcare provider that's approved by the network. So if you do a single case agreement where you're not part of the network, but you're taking a network claimant, and you have it in writing, then our fee guideline would apply. Or it's an emergency. Say you're taking call on the ER, and it's a network claimant. Any emergency services would be following our non-network fee guidelines. And healthcare for injured employees that do not live within the service area. And also pharmaceutical benefits. Pharmacy has been carved out of the network operations. So that's in the statute. So those are the exceptions where our non-network fee guidelines apply. Otherwise, your network contract applies. One concept that we want you to learn is MAR. When people say the MAR, it's maximum allowable reimbursement. So that's the maximum amount payable to you, a healthcare provider, in the absence of a contract. And it has to be consistent with Section Labor Code, which is our law or statute, Section 413.011, and our rules. I'm going to refer to 413.011 a lot. That's a really important chapter of the Labor Code for reimbursement and how we run the medical system in the workers' comp of Texas. So let's talk about workers' compensation network. Reimbursement for non-network healthcare. That means the injury is not subject to a network. So one patient can have two injuries for two different employers. They got hurt at two different employers. One could be non-network, one could be network. Your intake and verification needs to determine that up front so you know what you're dealing with. And so reimbursement for a non-network claim that you've verified should be according to our fee guidelines, or maybe you negotiated a contract, or if none of the above exists, a fair and reasonable amount. We'll talk about fair and reasonable a lot today. So fair and reasonable amount is and should be consistent with the Labor Code 413.011. And these are the criteria that are outlined in that statute. So if you are justifying a fair and reasonable amount to either be paid if you're an insurance carrier or requested by a healthcare provider, that means there's no fee associated with a fee guideline. It is left to fair and reasonable. It should, A, ensure that our injured employees are getting quality care. So pay enough to have quality care, but don't pay too much because we want to have effective medical cost control. And the last part is that fee does not provide for payment of a fee in excess of the fee charged for a similar treatment of an injured employee with an equivalent standard of living. So again, if you're trying to justify payment, fair and reasonable payment, you've got to show us how it is enough to have quality care, but not pay too much and be similar to somebody that's making payment for an injured individual that has an equivalent standard of living. That's what 413, that's what the legislature passed as the law for definition of fair and reasonable. So medical fee guidelines for professional services. This is 134.203 that's found in subchapter C of the medical fee guideline. Let's take a closer look at this one. In each rule, when you read it, there's going to be an applicability section, usually in A, right when you start reading the rule language. So this fee guideline, 134.203, applies to dates of service on or after March 1st, 2008. So this rule has been in place since 2008. Before 2008, for dates of service before 2008, there's a couple of other fee guidelines out there that still you can find in this subchapter. Now, the fee guideline 134.203 applies to professional medical services except those workers' comp specific services and codes like MMI, maximum medical improvement exams, impairment ratings, work hardening, work conditioning, functional capacity. Well, scratch the functional capacity evaluations, but there are specific services, and I'll go over some of those later on in the presentation. We have specific rules with CPT codes and fees in those rules. I'll go over functional capacity evaluations also later. Prescription drugs or medicine is not covered by 134.203. Dental services are billed on their own form, not on the CMS 1500. We have a fee guideline for dental services and medical services provided through a network. So this fee guideline does not apply to network professional services. That's found in your contract unless you meet some of those exceptions on that previous slide. The categories of services that are covered by 134.203 is E&M. Those are office visits, evaluation and management, general medicine, PM&R, which is physical medicine and rehab, radiology, durable medical equipment, laboratory, pathology, anesthesiology, the professional side, surgery performed in an office setting. So if you're doing some small procedures in your office, this rule applies to the professional part. Well, the only bill, that's the professional bill. And then also professional services related to a surgery performed in a facility. So when your surgeon is doing surgery while the injured employee is in a facility, there's two bills usually, right? At least two bills. One is the professional services, which this fee guideline applies to, and one is for the facility. That's another fee guideline. This is the AMAT that I was talking about. This is the all Medicare all the time. The rule says in the applicability section is for coding, billing, reporting, and reimbursement of professional medical services, the following applies. Now, I may not be capturing every Medicare payment policy here, but they all apply unless there's something different in our rule and law that supersedes it. So let's start with some of the main ones, and that is selecting CPT codes. Use the Medicare payment policies. When you're billing code pairs on a CMS 1500, there's something called National Correct Coding Initiative edits. These are NCCI edits. This is where Medicare looks at one CPT code compared to another. And they tell you whether a modifier is allowed to allow both of those CPT codes on one bill. They look at all code pairs on your CMS 1500. Most people have software in their clinics that will apply the CCI edits right up front, so you know before you even send the medical bill, especially if you're billing Medicare patients. You will have that software built into your AR system. So if you wanted to look at those CCI edits for free, say you don't have the software, I think Deanna is putting a link into the chat. You can look at cms.gov and search for NCCI edits. And it's a huge Excel spreadsheet split up by different CPT codes. You can look at your code pairs there for free. It's better to have the software, but you can look at it for free. All the modifiers that apply will be there. Now, HIPSAs and PSAs, if you don't know what those are programs that Medicare uses to pay incentive payments to health professional shortage areas. That's HIPSA. And PSA are physician scarcity areas, and you get another 10%. So those would apply, and any other payment policies in effect on the date of service for your bill. Now, we have our own incentive payment of 10%. We have a rule called 134.2. It is for workers' compensation, underserved areas. It's a list of zip codes. If you're performing services in those zip codes, then you could be entitled to the 10% on top of the MAR. But if a HIPSA applies at the same place as the workers' comp 10%, you don't get 20%. It's one or the other. So ours would supersede that. So, and then there are exceptions to Medicare payment policies. It's AMAT unless we say differently. So if you can understand that concept, we get a lot of calls into Comp Connection that says, well, what about this Medicare policy? Or, one of the large workers' comp insurance carriers is telling me to call you to find out what I should have done differently. My answer usually is, have you checked the Medicare website? Because that's where most of the answers lie. We cannot put all of the Medicare payment policies into our rules. You won't find them there. We're saying you go out and look for them, and we'll give you those resources during this presentation. Now, one of the notable exceptions to the Medicare policies is that if you're a chiropractor out there, you know that if you're billing Medicare, Medicare limits what you can provide to Medicare patients. And that is that you can only do a certain spinal adjustments for subluxation. Now, we know that chiropractors can bill all kinds of services besides just an adjustment for subluxation of the spine. You can provide physical medicine also. In the statute, Labor Code 413.011, again, that special statute citation for reimbursement, we have the chiropractic adjustment, if you will, and that allows chiropractors to become treating doctors and to practice within the scope of their license. So chiros, you can practice within the scope of your license, but say you're billing physical medicine charges, the same Medicare payment policies apply to those. You're not exempt from those. So keep that in mind. Medicare policy changes. Medicare changes a lot. And I went up and visited Trailblazer when they were a Medicare administrative contractor years ago, and they said that Medicare changes their policies every 8 hours. Now, not all of them will apply to you, but just know it's a moving train. So when Medicare changes a policy, it applies on the effective date for your service. If Medicare comes across with a retrospective, they announce it today, but it's going back 3 months, ours would start today. We're not going to make you go backwards in time. So just know that whatever was in effect on the date of service, that's what you need to look at. We don't do retrospective. Here are some examples of Medicare payment policies that do apply. And again, some is underlined because there are lots of Medicare payment policies. We used to have a graphic that showed a Medicare biller sitting next to a workers' comp biller, and we asked you to move their desks closer to each other because they need to be talking. If you know Medicare, you're that much further along for workers' compensation. So here are some examples of Medicare payment policies that apply. One, the MPPR, Medicare Multiple Procedure Payment Reduction, for services like therapy services, surgery services, and other applicable services. Medicare has a policy that reduces payment, looks at the largest one, then reduces the next one, next one, next one. That applies to you, chiros that are doing physical therapy, any physical therapy services, all of those Medicare payment policies apply. And the next one is the NCCI edits. That's the procedure to procedure or CPT code to CPT code. PTP edits, sometimes you'll hear them say that column 1, column 2, they've had lots of names over the years. But again, they're comparing CPT code to CPT code and deciding if those are bundled or not. And if they're not, maybe you can apply a 59 modifier. So if you're using your software, that will tell you, or you're going to the Medicare website and looking up those code pairs, it will tell you whether a 59 is allowed or not. Functional reporting codes, those modifiers, yes, they apply in our system. We don't have a rule that says they don't. So if Medicare is requiring them, we require them also. The last Medicare payment policy is that I want to mention, of course, there's lots of them, the CPT code time rule. This applies to timed CPT codes. So for the 15-minute timed physical therapy codes, anything greater or equal to 8 minutes equals 1 unit. If it's less than 8 minutes, no unit billed. Now, if Medicare changes any of these that I've listed here, we're going to change too, just like I said on an earlier slide. Now let's talk about some conflicting Medicare payment policies with our laws and rules. Again, the labor code and our rules take precedence or prevail over any conflicting Medicare payment policies. I'm going to give you some of the big ones. So we have a statute called 408.021 that's entitlement to medical benefits. This says that our injured employees are entitled to all that's medically reasonable for their compensable injury. It does not say we close the claim after maximum medical improvement. It does not say we close the claim whenever the carrier feels like the claim should be closed, because each service should be looked at for those two hurdles. One is it medically necessary? And two, is it for the compensable injury? So because we have that open, they're entitled to all of the medical services that meet that criteria. Any limits in the Medicare system would not apply. For instance, Medicare has a monetary, meaning a dollar amount cap for physical therapy every year. They adjust it every year. That would not apply. So if it's, I don't know what the amount is this year, but say it's $3,000. If the reimbursement gets to $3,000 in the workers' comp system, that does not automatically entitle the carrier to stop paying because of the Medicare payment policy, because it conflicts with 408.021. Also, the second set of edits, medically unlikely edits, MUEs, they do not apply in the workers' comp system because every service that you provide an injured employee should be looked at on its own merit, whether it's medically necessary for the compensable injury. MUE edits are how Medicare's automated some of those things they believe is not medically likely. So don't automatically apply MUEs. If there's any carriers on board here, know that MUEs do not automatically apply. We have a system for utilization review and for looking at either prospectively or retrospectively. That's our system set up to look at medically necessary healthcare. And we have another system set up to look at relatedness and compensability and extent of injury. The next one is licensed healthcare practitioners must submit their own bills. If you're licensed out there by the state of Texas to provide healthcare, you have to bill your own bill. And that is found in 133.20. We covered that in another webinar. But Medicare has what they call incident to billing. And that allows a license, say a mid-level, to bill under the doctor's license. That is not allowed in our system. You have to bill on your own license. Now, if the provider is not licensed, like a PT aide, they're not licensed as a healthcare provider. Yes, they can provide service and bill under the and the licensed PT would be billing. But no incident to. A license cannot bill under a license. And the next one. This one may be under the radar for y'all, but non-physician practitioner reimbursement. Medicare calls it NPP reimbursement, non-physician practitioner reimbursement. PAs, physician assistants, and nurse practitioners are non-physician practitioners in the Medicare system. We have a statute in 413.011. It points to the insurance code 1451.104. And it says that we shouldn't use a different payment method for PAs and NPs. I have some slides that will walk you through that. On the Medicare side, there's a lesser of calculation. We're not going to use that. Again, I'm going to walk you through step by step how a PA or a nurse practitioner would be paid, also known as non-physician practitioners. Now let's go to correct billing codes. Professional medical bills relating to 134.203 require you to use the most current level 1, which are called CPT codes, and level 2 HCPCS codes. So if you're wondering which code to select, you should have access to resources, either in your software or a book that shows you 2026 level 1 and level 2 HCPCS codes. Level 1 codes are maintained by the American Medical Association. Level 2 HCPCS codes are things, basically medical items. Those are maintained by Medicare. Those are updated every year. You need to be using current professional CPT and HCPCS codes and know the Medicare payment policies that give you some direction on which to select. And you select the billing code that best describes the highest degree of specificity the service you are providing. If you call us in Comp Connection and you say, I don't know which E&M code to select, or I don't know if my program is using the right CPT code, we're going to send you back to the description that the AMA provides for that CPT code. You are the best one to decide what you're providing and select the code with the highest level of specificity. Meaning, if you're going to choose a 9999 code, but there's a code that better describes it with higher level specificity, you need to choose the higher level of specificity. So that's what that means. Choose your codes wisely. So correct billing codes for workers' comp specific services. That's relating to the rules past 203. 134.203 is what we've been talking about. The rest of those rules, 134.210 through 134.260, require the most current level CPT codes and HCPCS codes. Also, we have some of the codes and modifiers listed in the actual rules. When you're selecting E&M codes, this is a special note to you guys. This is where you can get in trouble with the carrier. They're going to be looking for rock solid documentation when you select an E&M service. Now, if you know your resources, there are some resources at the bottom of your slide here. Selecting an E&M code these days is either based on medical decision making or total time spent in that encounter. So you have to decide which one you're basing it on, and your documentation needs to support that choice. So if you're going to choose total time spent, I would advise you to put a time in and a time out so that the carrier can see in your documentation. We do have a webinar out on our catalog and our digital library on documentation. So if you want to read more about that or listen to more about that, it's out there. But make sure your documentation supports the level of service you build, and know that E&M codes 99205 and 99215 are often questioned by the carrier. If you're going to choose those, make sure your documentation is rock solid so you can support that if you have to ask for reconsideration or go into either, if it's a network claim, into their process for appeal or into medical fee dispute resolution. Changing your codes. Say you get some adverse EOB from explanation of benefits from the carrier and you've billed 99205. They're going to say your documentation doesn't support that level. Well, you decide, you look at your documentation, you decide to change it. Please know that that could be a problem if you're changing it over 95 days. So select a good code that matches your services rendered. Be careful not to upcode. Ensure that your documentation matches and supports that description of the billing code, especially for timed codes. You want time in and time out. And submit the bill within 95 days. And if you're going to change one of those codes, it does not reset your filing deadline of 95 days. That carrier will look at it as another bill coming through with billing code changes. So if you're going to change diagnosis codes, CPT or HCPCS codes, do it within 95 days and meet your deadline. We're trying to give you pro tips here so you can avoid having denials for timely filing. But that's harder to overcome than adjusting your documentation and maybe your billing code. So let's go through examples of reimbursement calculations found in 134.203, which is the MFG, Medical Fee Guideline for Professional Reimbursement. Service categories. Again, we talked about this a little bit earlier, but to calculate the MAR, we're going to apply Medicare payment policies with our modifications, our exceptions for the following professional service categories: E&M, general medicine, PM&R, radiology, pathology, anesthesia, surgery while it's in an office setting, or your professional bill associated with a surgery while the patient was in a facility. Let's look at the Medicare reimbursement methodology. This is something that Medicare has been using for a long time. It is very sophisticated, and we attached ourselves to a standardized process, and that is this that you're looking at. So they take how much it costs for you to provide that service, that work expense, and adjust it for your geographic area. Those are called GPCIs, or geographic practice cost indexes. They add it to the practice expense. How much does it cost to keep your clinic open, times your geographic location? Because sometimes it's more expensive to provide services in Dallas versus the Rio Grande Valley. And then the malpractice expense times the malpractice GPCI. That gives you your relative value unit. That's a total RVU. And then Medicare multiplies that times their conversion factor. And that's a dollar amount. And that equals your Medicare reimbursement amount. That's the participating amount in Medicare. We've made a modification to this calculation, but that's the long calculation. Our specific modification replaces the Medicare conversion factor with the applicable DWC conversion factor. We have two of them. You can find these conversion factors on our website at that link right there, or you can go to the workers' compensation topics A through Z and click on C and look for conversion factors. These conversion factors change every year, starting in January, based on the Medicare Economic Index, MEI. That's basically inflation in plain terms. That is inflation. So the federal system cannot always base it directly on the MEI. They have to deal with budget concerns. So we are lucky in our system. We are basing our conversion factor off the MEI each year, and you've seen increases since the beginning of this fee guideline. Now, to look at it closer, I took a screen grab of what it looks like under C for conversion factors. These are dollar amounts. If you look at the rows, it'll give you the dates of service that it spans. So it's basically January 1st to December 31st. 26 is the first row. 25 will give you some history, what applied in 25, what applied in 24 and 23, and so on. And if you look across the top, those are the categories. You'll see that this year we have $72.07 as our conversion factor for most categories, including anesthesia. But if your doctor is a surgeon and he or she is doing surgery while the patient is in a facility, they're going to bump up to $90.48. So there's two basic conversion factors, $72.07 and $90.48. And this went up 2.7% from last year. And you'll see the percent increases each year there in that last column. So if you just take the short calculation, which I'll show you that one soon, and use our conversion factor compared to Medicare's, we're paying 216% of what Medicare would pay a participating provider for most in-office procedures. On the surgery side, we're paying 272% of what Medicare pays, but we're expressing it in a dollar amount as a conversion factor. Now let's look at the two calculations side by side so you can see how similar and what the main difference is. So again, the work times the GPCI, practice times the GPCI, malpractice times the GPCI gets their total RVU on the Medicare side, and they add their Medicare conversion factor, which is sitting at $33 or so. On our side, this is where we modified. So it's all Medicare all the time unless we change, and this is where we changed. And it's a good change. We added our conversion factor, which is higher than Medicare. So depending on the CPT codes you're billing, you would use the higher dollar amount or the lower one if it's in-office procedures. So just to compare, that's our modification. I'm going to take one example, and that is 99214 for an established patient visit in Austin, Texas for 2026. Again, this is non-network reimbursement. I went out to the CMS, well, the Novitas website, which is our Medicare administrative contractor for Texas, and I pulled these numbers. They're out there for you to look at and to program in your systems. And I took the numbers and I plugged them in. And then you'll see that their conversion factor is 33.40 and ours is 72.07. You see the difference in what a Medicare doctor would get, or excuse me, a Medicare patient for an office visit in Austin, Texas versus what you will get here in the workers' comp system. So 300.09. That's the long calculation. That's more exact. If you want the short calculation, which most people just want to know the percentage over Medicare, know that it can be off a few cents here. But if you took our conversion factor, divided by theirs, which they announce in the fall every year for the next calendar year, and sometimes they even change it during the year, but take it, it looks pretty solid right now at $33.40. So 7207 divided by 33.40 equals 2.16 or 216%. And you would take that percentage, multiply times the Medicare participating amount, and then you're going to get our approximate reimbursement. Taking that same CPT code, there's the calculation. 7207 divided by 3340 equals 216% times what they pay equals your 300.41. Notice there's a little bit of cents off there. That's because I did the short calculation. It can be off a few cents. So it's approximate. If you want to do it right and get the exact cents, do the long calculation. Now to just tag on to what I said earlier about PAs and NPs. We should be using the same methodology because of that statute citation that physicians are paid at in the Medicare system. So in that system, you're getting 85% of what a physician is paid or 85% of 16%. The lesser of clause, Medicare has a lesser of clause that says you can either get paid that or 80% of your actual charge. That is not allowed in our system because our statute and rules supersede, and it conflicts with that. So you're going to get 85% of what a workers' comp doctor would get, or if you're a cyst surgery, you're going to get 85% of the 16%. There's no lesser of clause. Here are the steps if you're very interested in how a PA or a nurse practitioner gets paid. I just took the 99213 and I walked through it. Notice there's no lesser of clause of 80% of billed charges. Now let's go to other categories. Those were basically services. Those are things that are provided to the patient, done to the patient. These, in this part of 134.204, are things, basically, durable medical equipment, prosthetics, orthotics, and supplies, or DMEPOS, as we like to call it. These are alphanumeric HCPCS codes. These are HCPCS level 2. They are alphanumeric, start with A, E, J, K, or L. So any of those HCPCS codes that start with that letter and then have numbers afterwards, we say in our rule that you're going to get paid 125% of Medicare's DMEPOS fee schedule. We are going to give you that resource later on in this presentation. So you would look up the DMEPOS fee schedule and you would multiply times 1.25. Now, if Medicare does not have a code, have a published value for that code, then you're going to step down to Texas Medicaid fee schedule. Look on the Medicaid fee schedule. Again, we'll give you resources in this presentation. And if you find your code with a value, then you multiply the Medicaid Texas rate times 1.25. If neither Medicare nor the Texas Medicaid system have a value, then you're going to go to fair and reasonable, which defaults to 134.1. And that's important to know. Again, pick the code that describes the item you're providing to the patient as best as you can. If you're choosing a 99 code, you're going to fall into the fair and reasonable land, which is 134.1, and it's going to get a little bit more difficult. Speaking of fair and reasonable reimbursement, you'll see an F in 134.203 that if there is no value set by our rules, by Medicare, by Medicaid, you're going to go to 134.1, which also references that statute for 13.011. I'm going to give you an example here. Look at this CPT code 21899. It's an unlisted procedure of the neck or thorax. So with that 99 on the end tells me that most likely Medicare and or Medicaid will not have a value for that code. And this is not an AE, JK, or L that we were talking about previously. This is a service provided to, I believe it's a surgery provided to an injured employee. Again, find the billing code that's the highest level of specificity to what you're providing to that patient. And let's go through the step through of fair and reasonable. Step 1, does Medicare value this service? Here are the locations I would go. The Novitas Dash Solutions is our Medicare administrative contractor for Texas. And you can navigate to their fee schedule and look and see if this CPT code has a value. This is how it looks. You're plugging in that CPT code there on the top left. You're giving a date of service. You're telling it what state and what locality. So you would drop that down. There's 8 different gypsies in Texas. They call them localities, gypsies. Find the place because, again, Medicare adjusts depending on where the service is being provided. And you'll see here under fee schedule amount on that bottom left, the participating provider amount, either in office, which I don't think it's done in office, but when performed in his facility, it's 0. So that first step results in 0. The second step, does Medicaid value this service? Here are the resources for the Medicaid system. Texas Medicaid Health Partners, TMHP, is basically the MAC, if you will, but it's really the contractor for the state of Texas Medicaid. If you go to that website, you can drill down to their fee schedules, and I gave you that link there. I went ahead and pulled this CPT code and looked at it under physicians. I'm using the static fee schedule. You'll see there's a choice for static fee schedule, and then look under physician, and then look for that CPT code. It's 0. So this results in no value for Medicaid. Also, does the division have a fee guideline that gives you a dollar amount? And not in this case. We don't. Not for this 21899. So step 4, you're going to go to 134.1. So if there is no value by all those other steps, you're going to go to 134.1. 134.1 is not going to give you a dollar amount. It's going to say that 1, division fee guidelines, that's a no. Do you have a contract? Do, that one takes precedence. In the absence of a contract or a value from the fee guidelines, it's a fair and reasonable amount. And for 13.011 and 134.1 give you some criteria to base your request for fair and reasonable. You need to make sure that it's consistent with these criteria. And the criteria says that it should ensure that similar procedures provided in a similar circumstance receive a similar reimbursement. So if I'm you, I'm looking around to see what is very similar and what am I getting paid in other situations. You can base it on nationally recognized published studies. I mean, a lot of you may have data on what is paid for that service. Published DWC medical fee dispute decisions. That is a skill set you probably need to have, and that we publish our MFDR decisions out there, and you can search by keyword. We will go over that in one of our other webinars called Medical Fee Dispute Resolution, how to search, or you can go to M for medical fee dispute decisions and get instructions on that web page. But you can look at previously decided MFDR decisions to see how the auditor resolved that dispute over fair and reasonable. You could use it. Doesn't mean it's always going to go that way because each MFDR request is looked at on its own merits. And I can tell you the requester has the burden of proof to determine what they're asking for is fair and reasonable. Or you can use values assigned for services involving similar work or resource commitments if you have that available. So if you're writing a position statement during reconsideration or during MFDR, use these criterion to say that you met that. So what is the best practice here? Develop that position statement or rationale. Or if you're on the carrier side, what method are you using to pay a fair and reasonable CPT or HCPCS code? Both sides have to have some rationale. We have a lot of disputes sent in that says, pay me X. They're not saying why or how. If it's a fair and reasonable CPT or HCPCS code or service that doesn't have a value to it, you need to tell us. Accompany the position statement with supporting documentation that shows you're consistent with 413.011 or 134.1. It's best to use this information during negotiations before you provide the service. That's the best option. But maybe it's after you've already given that item or provided that service. That's not recommended, but if you're in that position, you're behind the 8 ball a little bit, but you can provide this rationale to the carrier during reconsideration, or if you have to ask for dispute resolution in MFDR, provide it in a position statement there. If it's a network claim and you're in the network, you will have to follow the network appeal process. And it's good to have a rationale for that also. Here are some medical fee guideline resources. We have what we call an FAQ, frequently asked questions, relating to 134.203. It is a valuable resource. So if you go to M under our workers' comp topics A through Z, go to medical fee guideline, you can see the FAQs out there, and it covers a wide variety of topics. It talks about when you have HPSAs and DWC incentive payments apply at the same time, what happens, DME, durable medical equipment fees as it relates to MEI. Actually, it doesn't relate to MEI, and that's what it says. Clinical pathology, laboratory calculations are out there. Anesthesia, if we have any of those assistant participants on the line, those calculations are out there also. And there's a lot of other topics in those FAQs, so pay attention to that. Here are some resources for you. CMS, remember AMAT, all Medicare all the time unless we say different. CMS is the umbrella website. This is where everything is done on the federal level. And then you can also look at the fees on the CMS website, or you can look in our local administrative contractor, which is Novitas-Solutions. For most professional services, for those items that fall under DMEPOS or things that you're providing to the patient, the MAC, Medicare Administrative Contractor, is CGS Medicare. And you can go there and get the DMEPOS fee schedule, although you can find it on the CMS website too. So the difference between Novitas and CGS is CGS are things, the AEJKNL, and Novitas are the services, your professional fees. The Medicaid fee schedules, TMHP, and when you're there at TMHP, you're going to go under resources and look for the fee schedule lookup and use the static fee schedules and look for your provider type. It's an Excel spreadsheet, and then look for your HCPCS or CPT codes from there. TMHP. Now let's go into the workers' compensation specific services, 134.209 to 230, subchapter C. We've talked about this a little bit, but in these rules, you're going to have the description of the services, the CPT codes, the modifiers that are required, and the reimbursement amounts. As opposed to 134.203, we don't have any dollar amounts in there. People call us all the time and say, I want to know where the fee guideline is on your website. You're not going to find it on our website. You're going to have to go to CMS or Novitas. For these specific services, however, you can go to the rule language and find the description of the services, the CPT codes, and the modifiers and reimbursement amounts in most cases. 134.209 is the applicability rule that kind of gives the setting or the backdrop for these workers' comp specific services. And it just talks about what it does not apply to. In 134.210, it says that the coding, billing, reporting for workers' comp specific codes and services are included in these rules, and which services are paid with the DWC incentive payment and list of DWC specific modifiers are all in that rule 210. So if you want to know the workers' comp modifiers, they're all listed in here. If you're billing professional services, the modifiers that Medicare requires are used in our system, but for workers' comp specific services, you'll find them all in 210 here, 134.210. Now let's talk about home health services, 134.215. It is a one-line fee guideline, and it says that it's used for licensed home health agencies. So if you're a licensed home health agency, this fee guideline applies to you. And it says that we will use 125% of what Medicaid pays you. And Medicaid's paying CPT code by CPT code or HCPCS code. You can find that fee guideline on the TMHP website, as opposed to Medicare, who pays a lump sum for home health. That's not how we do it. We're going to pay like Medicaid does if you're a licensed home health agency. So that's in 134.215. 134.220. This is an exception to where I say use current CPT codes. We can make modifications, and we do. We don't usually like to get stuck in time with CPT codes, but this is one case, this is one instance where we do. This rule covers case management services. And this is where the treating doctor is providing case management services for coordinating medical care and return to work options. We value case management because our mission is to provide high quality services to the injured employee and to help him or her return to work. It is a shared responsibility, and we want to reimburse you for that work. It applies to treating doctors or referral healthcare providers. It gives CPT codes, modifiers, and reimbursement amounts in this rule. Now, because the CPT codes we have listed in the rule have been since deleted by the American Medical Association, these codes are 99361, 62, 371, 72, and 73. We have a frequently asked question in the medical fee guideline FAQ number 7 that describes what those services are. If your treating doctor wants to bill for case management codes, I would go to the MFG frequently asked questions number 7 and read the description of those codes, because you won't find it in your CPT code book today, because in 2007 AMA deleted them. We keep them alive because we value this service. So be careful if you're going to choose one of those that you're actually providing what the description says. Find those descriptions in question 7. There are team conferences, telephone calls with outside interdisciplinary teams. Your documentation should support the CPT code you select here. And here is one example. 99362 with a W1 modifier. This is, the description says, medical conference by a physician with an interdisciplinary team of health professionals or representatives of the community agencies to coordinate activities of patient care, patients not present, and you're spending an hour. The treating doctor is going to get 198 using that CPT code, and any contributing healthcare provider, they're not going to use a modifier. They can get $50 for doing that same thing there. So that's just one example. Take a look at question number 7 and see the other instances. You may be missing out on revenue here. The next workers' comp specific rule I'm going to go over is 134.225. This is functional capacity evaluations. For an injured employee, for that injury, remember, one person can have multiple injuries or claims, we call them. Each injury is only allowed 3 FCEs, functional capacity evaluations, per claim. However, DWC ordered FCEs don't count towards those threes, like DDs, designated doctors ordering an FCE. You'll use the 97750 with modifier FC, and it's billed per hour with a max here listed in the rule. 4 hours for the initial test, max of 2 hours for an interim, max of 3 hours for the discharge test, unless it's the initial and only. So reimbursement found in 134.203. So this rule happens to point back to 134.203, which is take the Medicare amount, multiply times 2.16 in this instance, and that's where you get the reimbursement. Documentation is required and outlined in the rule. Make sure you read this rule because there is a description of what an FCE includes. It's a neuro exam, it's a physical abilities test. All of these elements have to be included in your documentation to qualify as an FCE. So make sure you read the rule and get all of that included. So medical fee guideline for workers' comp specific services. These are the comprehensive programs that are offered to our injured employees. 134.230 covers work hardening, work conditioning, chronic pain management programs, and outpatient medical rehab programs. And these programs should meet the criteria and standards outlined by the Commission on Accreditation of Rehabilitation Facilities, or we call it CARF, out of their manual. It doesn't mean you have to be accredited by CARF to provide these. It means that you need to meet those standards found in that manual. So make sure your program meets these definitions. If you are billing for something else that doesn't meet these definitions, then this rule doesn't apply to you. You need to know that if you are CARF accredited, you can get 100% of the MAR listed in this rule. If you are non-CARF accredited program, you're going to get 80% of what's listed in this rule. If you're CARF accredited, you need to append your modifier with CA, meaning you're CARF accredited. The carrier can question if you're adding a CA and you're not CARF accredited. Just because your program meets the standards of the CARF manual doesn't mean you get to append with a CA. You have to be officially accredited by CARF to add the CA and get 100% of what's listed in that rule. Otherwise, you're going to get 80%, and you should not use a modifier. Now let's go into miscellaneous reimbursement. That is in subchapter B, miscellaneous reimbursement. Let's go through those rules. 134.100, it outlines reimbursement for a treating doctor that happens to attend a required medical examination for their injured employee. So an RME examination is basically a carrier-selected doctor conducting an examination on your patient if you're the treating doctor. Sometimes the injured employee or patient wants you to go with them, or you want to go with them, and you have to get a permission from the injured employee, and you can bill for that. So that's outlined in 134.100. It's basically $100 an hour and limited to 4 hours. This is only for treating doctors. 134.110, it talks about miscellaneous reimbursement for the injured employee. So if the injured employee has to travel one way more than 30 miles, they might qualify for some reimbursement. The injured employee, are the ones that fills out the form, which is the DWC form 48, and they bill it to the insurance carrier. So that is an injured employee type rule there. Now let's get into one that we do use a lot, 134.120. This is reimbursement for medical documentation. So it addresses the insurance carrier's obligation to reimburse for medical records or documentation. Generally speaking, this does not include copies of EOBs or bills or duplicate copies of medical documentation. So the insurance carrier is not required to reimburse the initial copy of medical documentation that you, the healthcare provider, sends to the carrier. So you're sending your bill plus records. The carrier doesn't need to pay for those records. But if it's subsequent, they could. Upon request, the healthcare provider shall provide the injured employee or their representative initial copy of medical documentation. Now, if that requester, say it's an attorney, wants more copies, requesters must pay for the additional copies. Sorry about that. Reimbursement amounts can be found in the rule language. A note that medical records sent from the treating doctor to a designated doctor related to a designated doctor exam states that reimbursement shall be made according to this rule also. So if I'm a treating doctor and I get a request to send all records related to that injury to the designated doctor, the carrier will pay for that according to this rule. So reimbursement for records provided to Office of Injured Employee Counsel. This is OIC, we call them. They have their own set of administrative codes, and you'll find in 276.11, which is entitled Access to Injured Employee Medical Documentation. So a healthcare provider's reimbursement from an insurance carrier for costs of documentation provided to OIC are prescribed by the provisions of 134.120, which is on the previous slide. So carrier will have to pay according to 134.120. Just to go over one more time, in Rule 127.10, this is the general procedures for a designated doctor exam. You're going to get asked if you're the treating doctor to send records, and the insurance carrier will cover the cost of those records. Do not send duplicates or EOBs and bills. They're looking for medical records here. And 134.120 governs the reimbursement for that medical documentation. Now, can we talk about late payments here? Rule 134.130 is both for the healthcare provider and the carrier in this rule. So interest for late payments on medical bills, if the carrier's late, or refunds if you, the healthcare provider, have been asked to send money back. So talking about insurance carriers first. Insurance carriers must pay the interest on a medical bill when they pay it on or after the 60th day after they originally receive a complete medical bill. If you're wondering what a complete medical bill is, we covered that in our billing webinar, and that comes out of chapter 133. On the healthcare provider side, if a carrier asks you for a refund, you shall pay interest to that insurance carrier on request for refunds paid later than the 60th day after the date the refund request was received. So it could be either you or them are going to owe interest on late payments. The interest rates are determined by the division. The statute sets out those criteria for 401.023. So we have the interest rates published quarterly on our website. And here are the steps to calculate those payments. And I wanted to take you there real quick. You should see my webpage now. This is our website. Again, this is a huge website. If you're using this A through Z right here, that's for the entire website. Don't use that. You're going to click on this, workers' comp, and you're going to go down to our A through Z. This is much easier. You can almost find anything here. It's pretty logical. If you go to I for interest rates right here, this is where the page is discussing interest rates. Here are the rates published, and here is a calculator. Your slide gives you the steps, but you would have to download this and know that there's a calculator out there. So you could put the amount of your bill and calculate out, or the amount of the reimbursement and calculate out the interest there. So you put in the date they should have paid, that sort of thing, and you're going to get your rate there. Or for carriers looking for refunds, same thing. So I just wanted to show you that tool is out there. And here are the links to that. When you pull up that, download that big Excel calculator, note the instructions are on the first tab. The calculator is on the second tab. Just make sure you go all the way over to medical bills because income benefits are in there and all kinds of things. Go all the way over for medical bills, and interest rates are on the last tab for that Excel spreadsheet. So if you didn't know, now you know where the interest rates can be found and how to calculate them in our system. A recap of what we talked about today. We talked about Chapter 134, the MFG for professional services, reimbursement calculation examples, fair and reasonable, workers' comp specific services, and miscellaneous reimbursement. It's a lot to cover. It is 1:10 right now, and we're going to exercise your brain. Let's start with question number 1. If a Medicare payment policy conflicts with the Texas Labor Code or a rule, the Texas regulation would prevail. True or false? Most of you answered it right. It is true. Remember, all Medicare all the time, unless we say differently, and we do in some instances, ours would supersede or prevail. Number 2, healthcare providers should bill using the most current CPT or HCBASE codes along with Medicare reporting and coding policies with a few exceptions. Those are case management codes, and that is true. Most of you got that right. Number 3, the workers' compensation non-network professional reimbursement for office visits is the exact same amount that Medicare would pay. That is false. We pay 216% of what Medicare pays right now this year, 2026. Number 4, the best practice is for a healthcare provider to have a rationale for the amount they are seeking for a service that's reimbursed at fair and reasonable. That is true. I'm glad most of you got that right. And number 5, there is no limit to the number of FCEs not ordered by DWC for an injured employee can have. That is false because it's 3. Next time, we're going to go from the ring swing to the unstable bridge here. And it's going to be a webinar entitled Pre-Authorization, Medical Necessity, and Utilization Review. We want you to learn what the statutes and rules say about medical necessity, how to justify that, and know the treatment guideline for non-network claims, and understand the pre-authorization process. Really important stuff. Now, if you have questions about anything, workers' comp related, healthcare provider or carrier related, please contact us at Comp Connection 800-252-7031, option 3, or you can email us at compconnection@tdi.texas.gov. We really appreciate you watching this video today. Thank you so much.